Hello and welcome to this edition of The Heart of West Virginia, where we are exploring issues related to the lungs, in particular lung cancer and lung cancer awareness, early diagnosis and treatment. Joining me is Dr. Saiesh Voppuru from the WVU School of Medicine, who specializes in thoracic surgery. Doctor, good to see you. Welcome. Thank you.
Thank you, Hoppy. Thank you for having me.
So lung cancer is one of the leading causes, if not the leading cause, of cancer deaths globally. Why is that?
As we know, it's possibly a multitude of factors, most because of the risk factors associated with it. Smoking being the most common, and it accounts to more than 90% of the deaths associated with lung cancer. And there are other causes, such as radon exposure, the environmental exposure to pollution, family history, and so on and so forth. So unfortunately, yes, that has been the trend with increasing incidence and mortality worldwide, and also a reflection of what is going on locally in West Virginia.
Yeah, and expand on that because in West Virginia we do have one of the highest smoking rates in the country, so therefore a higher rate of lung cancer, correct?
Yes, that goes hand in hand, like you correctly said. West Virginia is possibly number one or number two in terms of smoking and also the lung cancer incidence.
Mm-hmm. Explain, if you will, as you would explain to a patient, and you can throw in some medical terminology as well, is that how does smoking cause cancer in the lungs?
So smoking, as you know, is in several forms. There's cigarettes, cigars, there's vapes, smokeless tobacco. There are several chemicals that are called carcinogenic or known to cause cancer that are associated with smoking. And when we inhale, the lungs take the first hit with all these chemicals. And these chemicals cause genetic changes in the cells, and that induces cancer. That is the usual pathway. And like lungs are the first defense against anything that we inhale. So that goes hand in hand with why we see this.
What are the early symptoms?
The symptoms are usually non-specific. And that is one of the biggest challenges that we face, because you may have a cough, you may, feel some pain, or you may have some weight loss. But then most of that is attributed to, oh, maybe I have a flu or something else. And then that's usually missed until later on when things don't improve and then everything worsens. And then we see patients presenting in late stages because of this reason.
And I want to get to that. But so someone may have a cough, which could be associated with just smoking, right?
Yeah.
But also could be early signs of cancer development, correct?
That is true in a way. Since it is not specific, any process that can irritate the lungs could produce a cough. That could be just because of smoking. Or a flu, or someone who has a COPD or something else could have that attributed to it as well.
So how do you get an early diagnosis? I mean, who should come see you and describe that early diagnosis?
That is a great question. So this is where screening comes into play. So lung cancer screening has shown to be effective in terms of reducing mortality in those who have been screened. So several studies, large-scale studies across North America, Europe, and also Asia have shown that people who are deemed high risk for lung cancer, which there's a definition of but basically long-term smokers, 50 to 80 years of age, they would qualify for screening, which is in the form of a low-dose CT scans done every year. And these have helped pick up lung cancers in the early stages, which again would lead to better treatment results and outcomes.
Would you advise anyone who is a lifelong smoker who is 50 and older to get screened?
If they do qualify for the high risk category, yes. Anyone 50 or older having smoked 20 pack years or higher and continues to smoke right now or has quit within the last 15 years.
How does the screening work?
So screening is done with the help of a low-dose CT scan. People have tried using X-rays in the past, but they've not been very effective. So the low dose, I emphasize, is that the dosage of a regular CT scan you may have is about 8 times higher when you do a low-dose CT scan.
Okay.
So it gives us enough information to look at these spots that show up on the scans, which are called nodules, which may need further workup.
So you're looking for these nodules. So you're looking at the screening, and what are you seeing, or what are you looking for? Tell me more about that.
Right. So when we do these scans, we look for these nodules, which are essentially spots in the lungs, and then we see if they're new and have they been present before. If they have been present before, have they been growing? Have they been the same? And then we take into account the other risk factors the patient may have, and then we see, okay, does this, and there's a whole category of classification for these nodules from which is called lung RADS, which we employ in clinical practice, and then we see which way the patient needs to go. Do they need follow-up, or do they need biopsy? Do they need surgery?
Okay. It sounds like you should also get screened to get a baseline, right? So there's something to compare it to. Is that correct?
Right. Yeah. So once we start the screening, that will serve as a baseline, and then we do annual screening every year until the patient has passed the 15 years of quitting smoking, or another health problem arises, or if they are diagnosed with lung cancer.
If you have these nodules, if you see the nodules the first time, are you going to do more at that point to try to, in terms of biopsies and those kinds of things, or are you going to wait to see?
That will depend on the risk categorization of the nodules. So if someone has a nodule which shows up as a high risk based on what it looks like, their underlying risk factors, then yes, they may need additional studies, for example, a biopsy. Versus someone who has a very small nodule and it doesn't look very suspicious, they may just need a follow-up scan.
Okay.
Yeah.
So describe then the analysis that you would do if you want to do a further analysis. What would be your options there? How would you proceed with the patient?
So then you would look at the patient and see what their risk factors are in terms of any other health comorbidities. Like smoking goes hand in hand with several other.
High blood pressure, diabetes, obesity, those kinds of things.
COPD.
Yes, COPD.
Very important. And we use other tools of imaging, such as a PET scan, to further risk stratify the nodule that we find. And also then we may need to do a biopsy to ascertain what that nodule could be.
So when you do the biopsy, what do you get from the biopsy, and what are you looking for there?
Right. So the biopsy is it's accurate in about 85 to 90% of the cases, meaning we get what we're looking for.
Okay.
And that could be anywhere between benign, meaning it's just inflammation, versus different varieties of lung cancers.
And there's small cell and non-small cell? Is that
Broadly
correct?
speaking, yes.
Yeah. And so elaborate on that, if you will.
Of course. So more than 85% of lung cancers are the non-small cell variety, which is most commonly seen. 15% or so would be the small cell variety. And the small cell is the more aggressive variety, which is known to spread to other parts of the body by the time we actually get to it. Now, the non-small cell, which is the more common variety, again, has multiple subtypes in it. There is adenocarcinoma, there's squamous carcinoma, so on and so forth. So the treatment of these two will depend on, again, the subtype and also the stage at which they present.
Okay. So let's imagine a patient, and the patient has the small cell, which is the most common, but the least aggressive.
The non-small cell.
Non-small cell, right. Most common, but least aggressive. Is that
Lesser, less aggressive.
Okay. Yeah. So let's take that, for example, and you have the patient, and that's been diagnosed. Now, take it from there. What are you going to advise the patient to do? What might the treatments be?
Right. So the treatment for a non-small cell would depend on the stage at which they present. So when a patient comes with a nodule and then the biopsy shows that it's a non-small cell, then we need to make sure that we have complete staging information. Now that would include a PET scan and in most of the cases also an MRI of the brain.
Of the brain?
Yes.
Because
lung cancer has a predilection to spread to the brain, and it may be asymptomatic at the time of diagnosis. Even in early stages, maybe less than 10% of the patients, but it still warrants looking at the brain.
So you're still trying to find information then at that point.
Correct.
And then treatment is determined by what you find.
Exactly.
Yeah.
Yes.
Yeah.
Yes.
So describe some of the treatments or common treatments when you have the non-small cell.
Of course. So as we talked about, it's going to be stage dependent. For early stage cancers, the standard of care in those who can tolerate it would be surgery, meaning removing that part of the lung that is affected. Now, surgery not only is therapeutic, but it also adds more information in terms of whether or not it's gone to the lymph nodes or not. And that will have implications in additional treatment later on. For those who are not candidates for surgery or who would not want to have surgery and would like to explore other options, then radiation is an option. And there are other treatments called ablations, which can also take care of small, early stage cancers.
How about small cell?
Small cell, like I said, is quite aggressive. So it's rare to find. Maybe less than 5% of the cases are usually found in the early stages, where surgery is still an option. But overwhelming majority of them present in late stages, where chemotherapy and or radiation would be the way to go.
In surgery, and you've talked a lot about the stages that may exist with the cancers. Can surgery fix the patient, heal the patient?
That's a great question. So answer is yes. When we talk about treatment, we talk about long-term cure, meaning getting rid of the cancer and staying that way. So in early stage cancers, when they have surgery, they do have cure rates of upwards of 80% in some cases. But again, the caveat would be that whatever caused the cancer in the first place in one spot, the same risk factors were also present in the other parts of the lung.
Okay.
So it's important to keep them under surveillance to make sure that some new cancer nodule may not pop up elsewhere.
Is most lung surgery now robotic?
There is a growing trend of robotic surgery being offered for lung cancers, yes.
Okay.
Yeah.
And you do robotic surgery. And describe the benefits of robotic surgery and what you can do here at WVU.
Absolutely. So robotic surgery has been a revolutionary step in advancements of surgical treatments, where we do surgery with small incisions, and then we can get the same cure rates and equivalent survival rates as you would get with a big open incision. Now, the advantage would be lesser pain, quicker recovery, faster return to work, and overall better well-being of the patient.
But not everybody's a surgical candidate, are they?
That is true, yes. So not only is the treatment catered to the stage of the cancer, but also to the overall health status of the patient.
So if somebody is really sick, is that correct?
Right. So surgery for lung cancer would put a lot of stress on their lung function as well as their heart function. So we look at several other tests when we select a patient for lung cancer surgery.
Are you still using is there still radiation treatment? And is that common, and how effective is that?
So radiation is also a very useful and valuable treatment option in those patients who would not be surgical candidates or who choose not to have surgery. It is comparable to surgery in terms of outcomes. Yeah, and also radiation has a different role when it comes to advanced stages, where it could be the treatment of choice.
Do you have cases, sadly, where the cancer is so advanced that you really have to move to palliative care, or will you, even with advanced cases, will you say, let's try these things first?
Right. So when it comes to advanced cases, that is usually a stage 4, as we call it, or metastatic settings. That is where we know there is no cure, meaning it's not going to go away completely. But however, they could be treated, meaning you can keep them under control and then add meaningful years to the patient's life. That is where a multidisciplinary team approach comes into play. And then we have options like chemotherapy, radiation, sometimes surgery could be an option in these cases, but that's in very selective patients.
Mm-hmm.
Yeah. But
Doctor,
unfortunately, we do see a lot of patients who would ultimately end up requiring palliative care.
how do you have that conversation?
It is always tough. It's never easy to break that news. But it's a support system that's required both with the family as well as a multidisciplinary team where we have a medical oncologist, we have a palliative care specialist, and a radiation oncologist. And yeah.
Mm-hmm. You've used the word cure a couple times.
Mm-hmm.
You can cure people?
Yes. Short answer is yes.
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 Yes. That is one of the significant advances that we've made in cancer treatment. It's not a death sentence anymore. So there is no role for nihilism when it comes to cancer treatment, because treatment could equal to cure in an overwhelming majority of patients.
Really?
Especially when they present in the early stages. So that is why the emphasis is on screening to make sure that we catch them early.
Do you tell patients, we can cure you, we will cure you? I'm sure you have to be careful
Yes.
how you say that.
When we word it, we say there is a big chance of cure. And this is what we can do and give you that chance of cure.
Mm-hmm.
Yeah.
What is the role of the patient in all this? Because you can only do so much.
Right. So when I talk to my patients about this, I tell them my job is to give you the options, explain the pros and cons of each option. Ultimately, it is you who's going to choose it because it's your body and it's your choice.
Mm-hmm. Are we, you've talked about robotic surgery. I'm sure that medicines are improving all the time. Do you see anything in the distance that says we can, you've talked about cure, but could even cure the most extreme cases? I mean, is there a silver bullet out there somewhere?
So far, we can only see a promise of what could come. There's been so much momentum that's been gaining in the field of molecular diagnosis and what we call precision-based or personalized oncology treatments. As the scientists tease out the different mutations in cancer, there are several new options of drugs which can target those mutations and can try to keep the cancer at bay.
Mm-hmm.
Is it completely going to cure them of the cancer in late stages, like metastatic? At this point, unfortunately, we don't have anything, but the future does hold hope.
Mm-hmm. So you mentioned personalized care, precision care. So there is research ongoing that you could have a greater body of information that would allow for personalized and precision care, correct?
Yes.
Are we able to do that now?
We do. So at West Virginia University, we do have a lot of ongoing clinical trials. So the answer to advanced cancers would lie in a clinical trial where we test out different therapy options in these patients to get them that one drug that would fit them best. Are
you seeing progress on that front?
We do see encouraging results.
Mm-hmm.
Yes.
Mm-hmm.
Every year there are new medications that come into the armamentarium of the treating physicians, and they've been showing great promise.
Doctor, what do you say to patients to individuals who are watching this, patients or maybe people who smoked and they're concerned about their health? What is what's your statement to them? What do you say to them?
I would say, do not ignore your health. If you have a PCP, please see them and discuss with them if you would benefit from a screening test for lung cancer. And if so, try to get there and follow up. And, there are options. There's always treatment options, and there's always scope for discussion and see what fits best.
Why does all this work appeal to you?
So I've always been passionate about treating cancers, and that's what my background has also been. I think historically there's been tremendous nihilism when it comes to cancers.
Nihilism?
Yes.
Like people thinking it's a death sentence.
Right.
Yeah.
But it's not so. And that is where my passion lies, and I feel that's my calling. Yeah,
You have hope.
I do.
Very
That's
good.
why I'm doing this. Yeah.
Very good.
Thank you.
Thank you, Doctor.
Thank you so much.
That wraps it up for this edition of The Heart of West Virginia. Dr. Saiesh Voppuru and the entire WVU Heart and Vascular Institute, we want to thank those folks. I'm Hoppy Kercheval. Appreciate you tuning in, and have a great day.